2023. Welcome to the first coding compliance roundtable of the new year. I hope each and every single one of you that's tuning in, logging on, and hanging out with Christine Hall, Paul Spencer, Scott Kraft, Terry Fletcher, and myself. Hope you all had a wonderful, wonderful holiday season, a very happy, healthy, and prosperous new year. I do want to say out of the gate, I want to send a shout out to a good friend of mine across the pond over there in England. His mum, MUM, was in a medically induced coma for the last several days. And she finally woke up today. Keith Mason, we're praying for you, your mom, your entire family. You're in all of our thoughts and prayers. And to show my support, I am wearing my Keith Mason rugby jersey. There we go. And if anybody, I know you probably can't see it, but that is the Mason Project. And if anybody's interested, I did put up a post about it over the Christmas holiday. It's for a wonderful charity, wonderful cause. This year, the compliance guy is going to be doing a lot of charity stuff with the American Cancer Association. I'm already working on stuff with them. I'm working on stuff with St. Jude's as well. So stand by and we'll keep you all updated. So with that said, I want to welcome Christine, Paul, Scott, Terry to our first compliance roundtable. I know Stephanie Howard is not with us today, but she will be back next week, which we are all going to be happy to have her back. And hopefully she'll be talking about coders insurance again. So with that said, I want to start with Scott because evaluation and management services for the inpatient setting took effect on January 1st. So let's talk about time. And then Terry, I want you to be thinking about the split shared services in the, for the inpatient setting, because there is and has been some mass confusion on that. So Scott, let's start there with you, and then we'll go around the horn, and then Terry will jump into split shared.
Sure. So I think in part this is just a reminder that in addition to the changes to the documentation guidelines that are now in effect in these other settings as it relates to medical decision making, the typical service time also changed in some cases by quite a bit for these services. And I still on occasion will run into an outpatient note where the provider is billing a level 4 based on time and saying that it's 25 minutes, usually more than half. I'm like, well, we haven't had to do that for a while. And I think it's important because some of these changes in the inpatient setting are somewhat considerable. 99233, for example, is now a 50-minute timed service. 99232, I have my book here, is 35 minutes. 99231 is 25. 99221 is 40. 99222 is 55, and 99223 is 75. So one of the bigger boosts was 99233, and there's a lot of providers who I work with who are very comfortable with that 35-minute time statement being a feature of their inpatient documentation. And I think it's important to think about it from two levels. On the one hand, with this increase in time from 35 to 50 minutes, there are additional activities that could not have previously been counted as part of the billable service that now can be part of the billable service. On the other hand, each of these patients is now considerably more time. And so if you start to add up the number of patients that the provider might see over the course of the day, if the provider's getting too comfortable documenting time and not being thoughtful about what that aggregate output is, what the time may, quote, feel like to them, we're going to run into some potential situations where the provider's workday will seem longer than is normal, rational, or in some instances possible. Now, as Sean started to point out, when we talk about split shared services and things like that, there are other qualifiers when we audit that we have to be mindful of, right? Like, is there time that's being spent by providers who are not necessarily the billing provider, and how's that being documented. But I think that's important to understand because I had that joke in I had that joke in 2021 that all of the 99214 patients, as their holiday present, got an extra 5 minutes with their provider starting in 2021. And the same, I expect to see some of the same this year, but I do think it's worth being thoughtful about the fact that these service times have gone up.
So, Christine, I know you're ramping up, as is Terry and Scott and Paul, to begin audits, most likely, you know, uh, after a month of the new year goes by. What are some of the things that you're going to be looking for, and what are some of the things that you're coming out of the gate educating your clients on with regard to the E&M 2023 changes for the inpatient setting?
Well, I'm reminding them that we're looking at the patient today. We're looking at what are they presenting today, and hopefully they're getting better. Like, I don't anticipate that every patient is going to start off with a 99223, be followed with a 9922233, and then have your 99239. Like, I would hope that we would start to see what I believe the original intent was, that you're going to go in and get better. They've even added some additional definitions in the medical decision-making category, that problem category, to kind of reflect that we have a way to say they're still hospital level care, but they're getting better. And the other thing that I think it was Scott that mentioned it, was these templates that are in the EMRs, that 35 minutes, you caught me on that one, where, where they're so used to using that. Were the templates updated? Are we ready to go? Were the questions asked last week, last month? Did we reach out to the EMRs? Have the updates been implemented? Because we can educate all day long, but if their tools aren't going to help them, then we're just repeating the problem, repeating that insanity there. So that's where I'm looking at it right now.
Paul, some thoughts?
My biggest concern, based on the changes to initial and subsequent hospital care, is the effect that it has on observation services. I think this has kind of been papered over as far as what a sea change this is. The only type of true observation services as compared to 2022 that we're still reporting the same way is when there is an observation discharge or an admit on the same day of a stay that lasts at least 8 hours. I would recommend that every person who is listening keep the pressure on their max to put forward useful guidance with regard to not only place of service 21 versus 22 on these codes, because these codes have a definition of inpatient and or observation care, initial or subsequent. But I also want to turn the attention to the fact that in the old days, when you had a consultation service on the outpatient side, you had to use something like an outpatient E&M service in order to report that, either new or established. And we really don't have clear guidance as to what to use in the observation setting. If it followed the inpatient standard that's been in place now for over 10 years, we would say, okay, one of those initial hospital or observation codes would be used, but that's going to be up to each individual MAC and each individual insurance carrier. I would certainly be querying the bigger payers that you have to make certain that everything is lined up, that you're reporting the right code on day one, which is yesterday.
So, Terry, let's talk real quick. Let's talk about the final rule and observation care, and then I want to move into the split shared services.
Okay. So one of the things when you talk about final rule, we're talking about Medicare. And so Medicare and then there's CPT, which we know that they try to work together, but then when they disagree, Medicare says, fine, and they stamp their foot and they kick dirt and then they create their own code. And basically they're just like, we don't like what you're doing, so we're doing whatever we want. And it'd be great to live a life like that, saying, fine, I'm just going to go create my own stuff, so that they can identify with what they want. But anyway, what we're doing there is basically seeing that when they don't agree, it's causing a lot of confusion for many practices, because the one thing that we talked about, I think the last time we were on, is that the acuity for an inpatient service versus an acuity for an ops patient is different. So to combine these two services from an admission standpoint is going to fall on the place of service for a practice as far as how are they going to get reimbursed. I know Paul was saying, what do you bill for the obs care when it's in follow-up? Well, the final rule came out and said, well, if it's in follow-up from anybody else that's seeing the patient from a consulting perspective, then you would bill with the office or other outpatient visit, depending on the status of the patient, new or established. They're not changing their rule, for example. But it wasn't clear in CPT, if it's not Medicare, what they want you to do. Do they want you to bill for a follow-up inpatient observation care code, or do they want you to bill for outpatient observation? So I'm trying to explain to clients, I wouldn't change anything in that. I would still do what you did before and bill the outpatient or office codes for any follow-up established after that. But circling back around to shared visits, I don't, it's interesting because this to me is very black and white, but it seems everybody else is saying, no, this is gray, this is gray, this doesn't really make sense. And part of it, I can see why. So if you actually take a fine-tooth comb through the CPT book, which of course I've got my trusty one here, one of the things that it says within the CPT book that I think is missed a little bit because everybody always wants to default to Medicare is that, and I like the chapter verse, page 12, the professional edition, the 1, 2, 3, 4, fifth paragraph down, it says a shared or split visit is defined as a visit in which a physician and another qualified healthcare professional both provide the face-to-face and non-face-to-face work related to the visit. So that's interesting because Medicare came out and basically said last year in 2022, well, it's not necessarily needed to be face-to-face for if you complete one of the elements in its entirety. But they didn't say, kind of like prolonged service, they didn't say that should be the norm. They said, but that's rare. If you're going to see a patient in the inpatient, then obviously there would be a face-to-face with the provider of record, who's the billing provider. But it's not clear. And so I could see one provider, one physician saying, well, I did all of the history. And since there is no defined what is a history, it's just whatever the provider thinks is pertinent. I could see them saying, and I did the whole thing, so I'm going to go ahead and bill out the highest level E&M in the hospital and call it a day. And from an auditing perspective, I would have a field day with that, but based on best practices, not based on, I guess, a specific factoid I had that regulation, that was inaccurate. So this is where it's a problem. First of all, please do not use this. This is to the podcast listeners, to the people who are out there. Do not use a shared visit for place of service 11. It's not allowed in the office setting. And two reasons why it's not allowed. One is because a shared visit can be for a new or established patient, and you cannot have a new patient under incident 2. Okay, so that's the first reason. The second reason is that also the billing provider needs to provide that information. And in the office setting, it would create too much of a physician coming in on the back end to a mid-level provider and just signing off on the visit. There would have to be too much trust factor there. And I've seen too much nonsense in that arena for that not to happen. But the whole reason that they created the split or shared visit regulation, in my opinion, I mean, I guess, Scott, you probably could speak to this too, and Christine, is the fact that there is an assumption, and I've seen this in my Medicare audits, that in a split or shared visit, the workflow is that you have a physician that's either in the office or attending to another patient elsewhere in the hospital. And there's a call for that physician to see the patient. They send their mid-level provider over, who works up the patient history, exam, excuse me, and then basically says, either calls the physician or contacts them, says, this is what I got. And then at some point they go over and they say, I agree. And then they sign off on the note, or maybe even complete the medical decision-making and bill it out under that physician. Well, since 2021, that's incorrect. So you have to make sure that now it's the substantive portion, which is completing one or more of the elements. They do advise that in the final rule that it should be the medical decision making, or who has more than 50% of the time. And that doesn't mean you say I spent greater than 50% of the time. You actually have to have the exact time on each side. But I think Medicare is going to try and really, because you also have to have the FS modifier, they're going to try and catch practices in some non-compliance here, because I think they're trying to save money with this. They only want to reimburse 85%. They don't want to reimburse 100% based on what they have seen workflows produce on a split or shared visit. I think they truly believe that it's been this much time for the physician or this much work and this much work for the mid-level. And from everything I've seen, I agree with them. So how this plays out.
Yeah, I was gonna say, I think from a documentation perspective, prior to this rules change, which I think is still a bridge with the history exam part, but you know, if you ask yourself, of the physician and the nurse practitioner slash PA, who did what percentage of the work in an average split shared visit? I mean, in my mind, it was probably like, you know, we'll stay with 85 and 15, right? It was probably 85% of the work being done by the nurse practitioner, and the physician would come in and do the 15. And so I think that this change was sort of like, we want to pay whoever does the majority of the work. This notion of the history exam or medical decision making was supposed to be a 1-year transition that is now at least a 2-year transition. And one of the things that I've said to some of my clients is, when you do the history exam or medical decision making, and I think this is particularly important with these new rules, if you do it in its entirety, that means in its entirety. And so I've seen a lot of notes where the nurse practitioner documents, you know, say 6 reviewed organ systems as part of their note, and the physician documents 4. It's like, well, you haven't done it in its entirety because this other provider who also saw the same patient did more than you did. So I don't know how you can say you did it in its entirety. But I do think, to your point, Terry, now that we're not level selecting codes based on volume of history or exam, it does create a loophole, for lack of a better word, for a physician who does not document very much, but is able to claim they did all of one piece of something.
Sean, if I can interrupt 1 second before you go. One of the things I already saw last year is I have a stack from one of the biggest payers out there of 300 records they're having me look at for shared visits. I'm like, already? This is from early 2022. And I was just like, oh my gosh. So they're like, no, we know for a fact that this practice, a very big one, by the way, is basically sending all these in under the physician and several physicians. And we know that the mid-levels are doing them because the PAs and nurse practitioners told us that they were doing all the work and the physicians were only basically signing off, but that they were supposed to do it one way. And believe me, when you're on production as a mid-level provider, you also want credit for what you do. So be aware that I don't think the mid-level providers, I don't want to call them whistleblowers, but basically brought this to the attention of the payer to look at, are trying to cause trouble. They just want their credit for where credit's due because it affects their paycheck as well. And when I saw some of this already, I'm halfway through it, I was just like, oh my gosh, I have a 70% error rate. So it's just, I mean, and it's blatant all the way through the documentation. And so, you know, and then I have to go back and check with the hospital. They actually had to look at cameras to see if the doctors actually even went to the hospital. And I was like, well, now that's something different. And they wanted to make sure the doctor actually was there because this particular provider followed CPT and said, we want both face-to-face and non-face-to-face. We're not going to let you slide on that. So it's just interesting because I think the commercial plans are starting to finally catch up with Medicare and realize that there's some money to be taken back out there when things are non-compliant.
But it goes back, Terry, to the whole thing that I don't think that providers are paying attention to the difference between that collaboration agreement and contracts that they're signing and the rules that are in that contract. I have a new client that I just started working with last month, and it came right out very natural. We bill all of our nurse practitioners, physician assistants under the physician. And I said, but you're not following any of the guidelines. You have a very high Medicare practice. What are you talking about, Christine? No. They're collaborated with the physician. So we're still seeing this.
Right. Without them being in the office. Yeah.
Yeah. Oh my gosh.
So let me, if I can, summarize for our listeners the split shared services. So again, for calendar year 2023, what happened was CMS finalized basically a year-long delay of the split, or if you will, the shared visit policy based on the established rulemaking that was created in 2022. For this, the policy itself determines which professional should bill for a shared visit by defining the quote unquote substantive portion of the service as more than half of the total time. The last 2 points are this. For 2023, just as you had to do in 2022, the substantive portion of the visit is comprised of any of the following elements, right? It could be a history, it could be performance of a physical exam, medical decision making, which I would strongly suggest play a key portion in anything your providers do, or spending more than half of the total time face to face between the practitioner and the patient as the individual who gets to bill the visit. And finally, keep this in mind, clinicians who furnish a split shared visit will continue to have the choice, as I said a moment ago. But remember, the more than half of the total practitioner time spent to define the substantive portion instead of using total time to determine the substantive portion is on hold until 2024. That's when that will go into effect. Okay. So did my summary kind of put it into perspective? Is there anything that I omitted, anything that I missed on that?
Inpatient only. We're only talking about inpatient.
Right.
We're not talking about in the office.
Well, if I were talking
Or
about
the
if I were talking about in the office, I'd be talking about incident 2 services. These are split shared services. Again, incident 2 and split shared services are not the same thing. So, excuse me. Terry, any thoughts? Paul?
I think you covered it. I just wanted to remind everyone the FS modifier is not optional. I think some people thought it was just for the mid-level provider. For Medicare, it's for anybody
no.
who bills the service. And that's
Yeah.
one of the things
No,
that we
that's
saw
how you
that
have
was-
to report it.
Yeah, you have to report it. Well, I have a practice that that was getting in trouble with the payer, and they basically didn't bill it on or didn't append it to anything the physician reported, only what the mid-level reported. And I was like, where did you get that from? They're just like, well, that's what we were told. I love that. Who told you that? I get that all the time. Who told you that? And they can't remember.
I
who
want to
told
go
them
back
that.
to, I want to go back to this comment because this is one of my favorites, right? And, this is from Betty. And, she basically says here, when I would have my client doctors report the 223 and 223 and 233s day after day, and then 99238, I would show them their patterns and state they were so awesome as their patients were very sick day after day after day. And then all of a sudden they perform a miracle and they're discharged home. Y'all, this is why utilizing a physician distribution analysis program, doing your own data mining is so critical. Understanding who's an outlier, understanding where there's an aberrant coding pattern, doing this way before your commercial payer SIUs do it, before the auditors in the UPICs or the ZPIC, not ZPICs, but the RACs, the MACs, folks, billing these high levels of service day after day after day after day and day, and then all of a sudden they're discharged. It's a problem.
Yeah, and don't forget no shared visit for the ER and no time element there.
Well,
I'm
and
seeing somebody mention that.
And I would just add to, I think what I think about with a comment like Betty's, as well as medical necessity, because one of the things that I've said on this podcast before, and I'm probably a broken record for the people who are around me outside of this podcast, is this whole data issue with these guidelines in the inpatient setting, where I predict a lot more documented conversations. And I've been reading some notes in the past couple of weeks where the hospitalist is like, well, I discussed the patient with GI, and part of me is like, well, the GI doctor totally handled the plan sufficiently, signed off. Like, and as a non-clinician, it's hard for me to say that those conversations are not necessary, but they're anchoring high-level services. And I think it's going to be an ongoing concern for me, at least, as I look at these notes, because it's very easy when you're bringing things forward to start to say, and I talked with the specialist again today. I talked to the hospitalist. So a lot of conversing happening. And one of the things I'm suggesting to the groups I work with is to start to think about putting a framework around either, one, what's allowed to be carried forward or not, because I don't necessarily know if these conversations are happening on a daily basis. And two, how to support the medical necessity of these conversations, because data in the office setting is one thing, but I could see data in the inpatient setting being a high. If I just walk through MDM and say, what's the problem? What's the data? What's the risk of the treatment? I could see data being high a lot.
Yeah.
So I want to share real quick, Paul. You just raised a great point. So the very last travel day that I had in 2022 was to travel to Michigan for a federal criminal trial, in which I was the technical and testifying expert in this case. And I got to be careful about what I talk about because it's still in jury deliberation right now. But one of the things that folks need to pay very close attention to in 2023, there's two things, okay? Two. One, 2022 was not the year of the audit, okay? Saying that 2022 was the year of the audit was insinuating that after 2022, we would revert back to the way things were. And that's not the case. 2022 set a new precedent to bring us into a new era, if you will, for auditing and investigations, both at the commercial and at the federal payer level, which includes Medicaid through the MFUCUs, okay? But one of the things that was very clear to me during cross-examination, okay, was that they are no longer interested, when I say they, the government, they are no longer interested in asking for 20 patients with one date of service, because what they're realizing is that you can't just look at a patient in a vacuum with one date of service. They are now looking at a chronology. They're looking at 5 patients with 4 dates of service, because this is how they are making a determination as to whether or not the notes are cloned. If they are seeing the exact same information, same history, same exam, same decision making, documented day after day after day after day, and you're billing level 3s, level 4s, whatever it may be, you are setting yourself up for being accused, having allegations, facing potential indictments. Folks, last year was my busiest year, and it's already off to a huge start again in 2023. I have 6 federal and criminal trials already on the docket this year already. What I'm telling you is you've got to conduct internal audits of your provider's documentation. If you don't have the resources to do it internally, do it externally. Christine Hall, Terry Fletcher, they have independent organizations that can help you with this. Scott Kraft, Paul Spencer, they're part of Doctors Management and NAMUS. They can do the same type of work for you. The point is, you need to know before somebody else does. And here's the other reason why audits are so critical in 2023, because the Department of Justice is going to begin looking to organizations who claim that they have a corporate compliance program for a compliance officer certification statement, and then a statement by the CEO of the organization that you have you have created a culture of compliance, and that when you do your audits, it is a bona fide audit of what's going on. All right, let me stop there. Christine, Scott, Paul, go ahead, please.
Yeah, the one other point that I want to say to add to this, and it struck me, because one of the things I find myself doing with these 2023 guidelines is I'm going into other notes beyond who I'm auditing to sort of attempt to discern who's responsible for orders and who's responsible for those types of things. And obviously some of this is going to be subjective, and a patient's condition changes throughout the day. But one of the things I'm struck by sometimes is the massive disparity between how a patient's condition is presented by two different providers, even when they may be treating the same problem, where I'm reading the note of the provider I'm auditing and I'm like, okay, this person seems like they are, practically at death's door. And then I go and I read the specialist note, and the specialist is like, well, the patient's greatly improved and the patient's coming off of this and they're potentially ready for discharge. And, I realized that in putting that comment out there, I realized there are a lot of individual factors there. There's the carry forward documentation versus what's being created today. But I think, and some of the things I talked about with the subjective nature of how a patient's assessed. But I think if provider A consistently describes a patient as being substantively worse and codes appropriately, based on, when I say appropriately, I mean based on what they're saying, and then every specialist is talking about how the patient's better, or every other provider, I think that's a risk that sort of sets there. And Sean's point brought it out to me, because we're so used to, at least in my world, I'm given a provider to audit, right? I'm like, today you're auditing Dr. Smith, and I'm hyper focused on Dr. Smith, but there's that realization that that's a risk factor that sits out there when you think about how these patients are being described.
A lot of that has to do with the fact that perhaps there are specialist groups and hospitalist groups that aren't employed by the same entity. So they're just kind of parachuting in, they're doing their portion, they're commenting on it, and they're not, maybe they have a phone conversation. We see a lot of notes in medical decision making saying, I discussed this with Dr. X. Well, when? But for some reason, there's not the communication that's needed to satisfy, is this patient better or is this patient worse?
Well, and I just, the main reason I think so much of that is problematic is like I've said before, I think getting to level 3 on a strict medical decision-making walkthrough compared to the past is now harder. And it's harder because the risk category is far more focused on the risk of the patient from the treatment versus just how many things does this person have and how bad are they?
Agreed.
Christine, any thoughts?
Well, I've been in the background kind of typing away there, and I can't agree with you guys more. I mean, I think this is the time that we look at internal processes. What does our program look like? Let's jump into it. New year, let's go. I talked about that last year. If you're looking for a resolution, your resolution should be, how are we doing? And don't be afraid. If it's bad, you have something to change. If it's wrong, you've got somewhere to begin. But you've got to get started. And just as you were saying, when you're auditing, that has become my MO. I am now looking at previous visits. I'm looking to see, what did you see one of my colleagues in the group who recommended this procedure? If A doesn't work, we're going to do B. Well, then maybe modifier 25 is not supported because we already planned this if A didn't work. Or more to what Scott was saying or Paul was saying, a patient in the hospital that's got multiple providers, and those providers understand how to select, so you can reflect how the patient's getting better. But the hospitalist is still stuck in that, this is what we bill for a subsequent visit, this is what we bill for a new visit, and they just don't jive. They don't show that progression that the patient's making appropriately. And those are red flags as well. We know data mining across providers at the payer end happens all the time, especially in the risk world. We get to see that. but I don't know that all of the provider groups realize that that's happening in the background, and they're leaving themselves vulnerable for Sean to have to come in.
Well, and the hospitalist as the summarizer of activities, and I find myself as I go through the notes, I see that happening quite a bit more, and you know, the hospitalist. If all you do is look at the hospitalist note, sometimes it may appear as though the hospitalist is doing many things, but the hospitalist is just describing using an active voice what's being done by other people, right? Like, we place the patient on a drug, right? Well, is this a royal we? Like, who is the we here? I find that concerning.
The other thing I wanted to
Go
bring
ahead,
up
Terry.
too is Sean said that this isn't the, you know, the last year was not the year of the audit, and it shouldn't be. I mean, I think this year should be the year of the compliance program. There you go, Christine, not plan, program. But the reason I say that is because I don't know how many of you all do this, but I can guarantee you all of us on this panel have heard this phrase. Well, my providers are doing this, and I need to start a plan so that we can figure out where it goes. So they're already doing something you know is not appropriate. And now you want to start the plan or the program. Be proactive. And I know I mentioned the word best practices. You don't want a Sean or a Paul or a Scott to have to come in. You want to be, you know, act on the offense instead of the defensive side, and know that you're doing it correctly, or at least making every attempt to do things correctly, and trying not to edge what you're doing, you know, well, it's technically correct. I hate that phrase. Well, it was technically correct. I can kind of do that. You're just asking for trouble. One thing that I've had providers say to me, a couple of them recently, how do I get around that? Oh man, you say that to me, I'm like, excuse me, I got to take another call, and you're on perpetual hold then with me. But it's just, I think one thing
I
that's
have to go to
really
the bathroom.
tough,
I'll be right back.
I know, got to be right back. But I think one thing that's really tough is when I see practices, and this isn't, I feel bad because coders, billers, administrators, healthcare professionals, you know, those of us on the paperwork end of things, not necessarily the clinical end. The doctors basically, they go into the OR or they go into the hospital and they chat with their friends and, you know, their buddies, both male and female physicians. You know, it's not one-sided, and they hear, oh, we're making money doing this, and then all of a sudden they bring it back to so they start doing it, they bring it back to their staff, and their staff's like, what is this that you're doing now? Oh, well, I heard, again, from that heard person, we don't know who they are. And then all of a sudden the staff is like, oh shoot, we just found out, you know, because we do our due diligence, that this isn't appropriate. And so now they're trying to backtrack. It's almost like backdating a claim. And you have to be, I mean, Sean, you could speak to that. What is the defense of somebody that says, well, my doctors are doing it before I can actually get a compliance plan in place? Is there a defense to that? I don't think so.
No, there's no defensibility of something like that. You know, deliberate ignorance, reckless disregard, those are indefensible. And
You said that so nicely.
that keep in mind that, you know, so there's two things that providers get prosecuted under. And it's not just providers. Remember, under the False Claims Act, right? It's any person who knowingly, right, acts in deliberate ignorance or with reckless disregard is held culpable, right? Now, the thing that a lot of people don't recognize about the False Claims Act is that they say it's an intent-based law, but it requires no intent. They do not have to demonstrate any intent. They just have to show that you knowingly submitted claims that were in error. So there is no defensibility. You know, what I will tell you is that irrespective of whether you want to spend money on a corporate compliance program or not, you need to. Because as I tell clients all the time, you're going to pay for it one way or the other. You're either going to pay a little bit on the front end or you're going to pay a whole bunch on the back end. And what I mean by a whole bunch is probably attorneys to represent you, to either take it to trial and hope that you get an acquittal, or hope that the things you get found guilty on are insignificant, that don't hold any jail time with it or any debarment. So remember, attorneys get disbarred, providers, healthcare professionals get debarred from the healthcare system. The healthcare fraud statute is a little bit different, right? Because the healthcare fraud statute allows you to paint, or allows a prosecutor to paint with very broad strokes. They do not have to demonstrate that there was any knowledge or any willingness or intent or reckless disregard or deliberate ignorance. They bring these claims, and once this litigation, this jury trial concludes this week, we'll talk all about it, because this was just absolutely mind-boggling what transpired. Okay,
And
I want to get to our next. Go ahead, please.
no, I was just going to say, Sean, I think an important part to remember about that, which I'm sure you know, is when it gets to the point where a prosecutor is involved, it's not always about finding the facts, right? Prosecutors like to win like anybody else. So when there's a prosecutor involved, prosecutor's trying to win, and the way the prosecutor wins is to find you guilty. And so, you know, that you don't really, when you think about being proactive and mitigating compliance risk, you don't want to be in that. That's not where you want to be working on your innocence, right? You want to be handling it a number of steps before.
Yeah, listen, you got to remember, attorneys are storytellers, right? Their storytelling ability hinders on their credibility, and it hinders on their likability with the jury, and or if it's a bench trial, a judge. That's why subject matter experts in these cases are so critical, and people who can actually hold their own. I will share with you one line of a question that came out of the case in December. And I want you all to hear this, because this was unbelievable to me. And the question to me was, quote, Mr. Weiss, so what you're saying is that just because something is documented in the medical record, that means it happened? And without fail, my response was, well, it doesn't mean it didn't happen. But the prosecutor raised a great point, and it's to the point that we've all been talking about. That's why cloning is a big topic for prosecutors, because they're looking at multiple dates of service, consecutive dates of service, and they're saying, Mr. Weiss, look at this date of service. Look at the HPI. Here's what it says. Look at the next date. Look at the HPI. Now, thank goodness for the prosecutors not reading completely the whole HPI and only trying to point out a small segment of it, because it hurt their credibility when we asked them to put it back up. And I was able to say, sure, the first part says the same thing, but look at the next two sentences. That was not there the day before, so there is no cloning. The notes are not identical. So you got to be careful with that stuff. Okay, I want to move on to something that's really unbelievable to me, and it happens all the time. Paul, you brought up a great article, and Terry, I know you had something as well. It happened not here in this country. I believe it was in the UK.
Yes.
Okay. So, Paul, I'll let you tell the story before. I don't want to steal your thunder.
So every medical practice, as part of their public outreach, wants to have some type of direct connection to a patient, whether it's social media or text blasts or something along those lines. Well, what we have is the case of a Merry Christmas text blast that at first, instead of a Merry Christmas text blast that came from one NHS clinic in the UK, actually was, if you read the first text that went out from this clinic, was informing someone that they had inoperable lung cancer. It wasn't particularly clear as to who it was being informed, but the story that I read was one gentleman got it. He turned to his mother, who was sitting there, who was also a patient of that clinic. She got it. And it turned out that every single patient of that clinic received a notification that there was inoperable lung cancer. And moments later, we had the apology text that said, "We're very sorry for that message. Have a Merry Christmas and a Happy New Year." So I mean, it's the absolute nightmare scenario of how to reach out and how to connect with it. And I've made this point before. This is a compliance podcast. You are only as strong in your compliance program as your weakest link. And a lot of it has to do with what we call HIPAA security. We can't tell you just how many times in big, large operations that it's that one person who didn't protect their password, or a person who chose a wrong website from their work computer terminal, and suddenly there's ransomware all throughout the organization, or they have put out, they've sent patient information to the wrong source, or something equally as ridiculous, or they've hired somebody who likes to laugh at other people's medical conditions and post them on Facebook. There have been some issues with that. You are only as strong as your weakest link. Now, the fact that this happened in the UK doesn't surprise me, because they went first on the government-run healthcare system carousel, and they have the worst medical system in the world. I mean, it's better to live in a refrigerator box than a long-term care facility in the United Kingdom. But you have to make certain. This is where compliance education comes into place. It's not just for the people in the office. It's for the people handling your reputation on a day-to-day basis. You can't help Yelp, because it's either going to be 1s or 5s. Nobody signs on and says it was adequate. I gave it 3 stars. But you have to be aware of what's being posted in your name and what's being sent out.
So staying on this topic, I want to shift to Christine. And we've all had some fun with Christine this morning, because she talked to Tex, and she brought up HIPAA, and it translated into HIPAA, HYPPA. So from here on out, it will be known as HIPAA. So
Yes.
Christine, let's talk a little bit about HIPAA, and let's kind of tie this all together here.
So, Paul, one thing I wanted to let people know is, we didn't corner the market on HIPAA. Other countries all have some sort of a data protection act in place. And it just goes to show that this can happen anywhere about anything. And I think we need to do the best we can to try to mitigate this, but that's all going to be included in your compliance program. Every compliance program that I've ever been a part of, or help write or help implement into a practice, protecting that information is the cornerstone of what our minimum obligation to our patients are.
One of the things that I will bring up, and then Terry, I want to kind of go to you, and then we'll kind of go around the horn. One of the things that Paul brought up was, you're only as strong as your weakest link. And, one of the things that you had mentioned was somebody who gets a kick out of, a patient's, medical plight, and posts it to Facebook or to TikTok or, Instacart, not Instacart. That's the shopping thing, isn't it? Instagram.
It would be a bad place to put it also, though.
Instacart would be a bad place to put it, but Instagram, you guys got me confused. There is malicious intent. Look, I have an 81, almost 82-year-old mother, and she lives in Boca Raton, and I have to do Instacart. So that was on my mind today. There is something called malicious intent, and malicious intent is the highest level of prosecutable offense, and highest penalized offense under the Health Insurance Portability and Accountability Act. That is why in HIPAA, we have something called the minimum necessary standard. And the minimum necessary standard identifies, or it should identify through an internal policy within your organization, who requires access to what aspect of the patient's medical records. And you should never just have blanket access for anyone who has a username and password to log into the system. There need to be protections put in place. Again, in 2022, I worked very closely in negotiating settlements with the Office for Civil Rights. Some of you may remember Teresa, Teresa Tullerson, excuse me, who was on my podcast, who talked about their organization being hit at the time for what would have been considered the largest single fine against a physician practice had we not gotten involved and negotiated it down. So take the time now here at the beginning of the year as you are starting to figure out your agenda. What are the most critical aspects of the things that need to be done in your organization? And it needs to start with compliance, not simply because this is a compliance program or, I get referred to as the compliance guy, because everything that you do in your organization is a result of your compliance activities. Don't sit back and wait for an audit. Don't sit back and think we're never going to get a civil investigative demand. Nobody's going to investigate us from, Mafuku or from a UPIC or from an SIU or from a SMRC. It's happening. And they don't discriminate. They don't care whether you're in rural Kansas or you're in a metropolitan part of California. They don't care. Terry, let me go to you for your final thoughts, and then we're going to go to each of our guests for theirs.
Okay, so I know that we always talk about the compliance manual as we talk about it in a healthcare setting, which obviously that's the profession that we're all in. But think about it as something like this, because just kind of feeding off what Paul was saying, one of the things that I just recently came across, and it was somebody that was taking videos in a doctor's practice, and putting them on TikTok of what people were talking about in the waiting room of other people's conditions. And I was like, you've got to be kidding me. But here's the thing, when we talk about compliance manuals, everyone has an employee manual, right? And you update that every year. You have an OSHA manual. And now with the pandemic and everything that has to go in there for, possibilities of that and how you have to have certain things to protect patients now from cleaning, et cetera, you have to have that updated. You need to have your HIPAA manual. Sorry, Christine, HIPAA. Just basically having all these things, but also remember HIPAA unfortunately has a loophole. It applies to entities, which actually aren't patients necessarily, but they are people who are involved in the patient care. So it would be anybody that's an employee of that provider's practice, hospital employees, providers obviously themselves. But if an employee overhears something in a waiting room and then goes to Starbucks and starts talking about it, they aren't held responsible for that, and they can't be. They're not a HIPAA entity. And, and I mentioned this, I don't know, about a year ago on a podcast I was on, where there was a big thing about, have you been vaccinated? And there was a bunch of Congress members saying that was a HIPAA violation for you to even ask. No, it wasn't. What violation? You couldn't even cite it. And so one of the things I just like to put out there and kind of in closing out today, you need to have somewhere white paper in writing, not just your compliance manual and what compliance means is if you don't do what the regulatory rules say, what is the consequence and how is that fixed? Is there a corrective action? But OSHA, employee manual, you should have a HIPAA, but also have a patient's 10 commandments. I started doing that in practices about 10 years ago. And what that is if you want to participate in care in our office, you won't share your insurance card. You'll pay your share of cost. If you hear anybody else's information in the waiting room, you will not share that outside the office. And that actually was a really big one because I had providers, once they instilled this in their practices, these 10 commandments, and they put them up on the wall. They said patients were so appreciative of that. They would come in the waiting room and talk to their doctor and say, thank you for doing the 10 commandments because I overheard this and that. And I wanted to make sure that nobody else heard it because I know that person who's a teacher at my son's school and I didn't want somebody else to hear that. So it's not about just your own personal information, but it's like a bad case of telephone, where it just gets over and gets everywhere. And just put it out there to your staff. And if you're creating these, hopefully you've started them into 2013 or 2000. See where I'm at? 2023. Hopefully you've really taken into account not just compliance from a billing perspective, but also from workflow. But all those things need to have a white paper direction for your staff on how things are done and what the consequences are. And that includes your providers.
Yep. Great. Scott, let's go to you for some final thoughts.
Yeah, I agree with Terry, and I think the point that I take away from that, we started this conversation talking about HIPAA, right? And I think Pam made a comment: why would a diagnosis of inoperable cancer ever be delivered by electronic media? And I don't know how they do things in England, but I agree with that. I'm not even sure, frankly, that assuming there was no PHI, I'm not even sure like that's a HIPAA violation. It's a terrible customer service. But I think Terry's point about office culture is important, right? Like, with TikTok, I just think everybody wants to be famous now. And so people are going to sit around and take videos. And, I try to be thoughtful when I'm in practices. What are they doing that's may not necessarily be a specific HIPAA violation, but may expose patients to some level of exposure that they may not want? Like, are they doing what is a best practice? Are they really training their employees on the importance of being cognizant of and protecting patients' information, even when it's not a per se HIPAA situation? And I think that those things are important. I think having a strong disciplinary mechanism in place for these things, like, it's not cavalier to talk about somebody else's health, right? It's not something that should be, a written warning type of situation. These are people, like, if somebody is willing to, look at somebody's health information and go talk to their friend about it at Starbucks, they're probably not a person you want to have working in your practice. So there's no point in going through and having these staged discipline, right? Like, every time I've had a job, there's always something in the manual that talks about, depending upon the offense, we may skip the warnings, right? And some of these issues are what I would consider to be skip the warning issues, right? So it's important that we understand, like, what is HIPAA from a violations perspective and what is not. But as you say at the end of every podcast, some of this is just about being good and right to one another during these interactions.
Yep. Christine, let's go to you.
Absolutely. I'm with the team here. I think that we definitely need to spend a little bit more time with our staff. That's why I always recommend not only having your updates, education updates every year, but have your compliance update every year. That includes HIPAA, that includes your OSHAs, not just a computer program that they're going to pay their 15-year-old to take at home. Have a meeting where everybody gets together and we discuss these things one more time. Remind them, no passwords underneath the keyboards. Remind them that, your phone shouldn't be out during the workday out in the workplace there. That, remind the staff on an annual basis. Repetition, that's how it becomes solid in our minds and our where we, I lost my word. But where your go-to thoughts are, right? If we keep talking about it, it becomes your go-to. So that's my take.
Great. Paul, and then I'll go to mine.
You know who I wish would sue for HIPAA more often? The attorneys of dying celebrities. And I feel this every time I go into a supermarket and I look at a tabloid and it says such and such a person is dying. Well, the first, my first instinct as a compliance professional is, okay, how do you know that? How did you get that information? Did the celebrity release that to a tabloid? Chances are about 99.8% that the answer is no. And I want to remind people that one of the very first HIPAA prosecutions was some medical records clerk in Cedars-Sinai Hospital in LA who was selling information to the National Enquirer, got caught, and he went to jail. And piggybacking on what Christine said, cell phone policies aren't about just use during work time. You better have a social media policy that's a double on the back end of that. It's omnipresent on every phone except mine, apparently. So make sure that if if obviously virtually every one of your employees is on social media in one way, shape, or form, you better have a social media policy and make it very cut and dry and crystal clear that information that is part of your work product is not to be put on social media in any way, shape, or form.
And that will tie right into my final thought, which is the only way to have policies and procedures is to have them in writing. You have to have a compliance program, including a compliance plan in writing. It doesn't need to be a 400-page document with all kind of legally, verbiage in there. It could be a 10-page document. It could be an 8-page document. As long as you are checking off the 8 elements, and I say 8 because of the risk assessment, which is number 8, you got to have that in there. If you don't have a corporate compliance program, reach out to Terry, reach out to Christine, reach out to me. Hell, they call me the compliance guy for a reason. Any one of us would be happy to assist you all with putting that together. All right, that's going to bring us to the end of our very first 2023 Coding and Compliance Roundtable. I want to say thank you all to Christine, Paul, Scott, and Terry for spending time with me today. To each and every single one of you who has tuned in, logged on, and hung out with us for this hour, thank you all so much. We have such a great lineup in 2023 coming down the pike. Terry and I will be back tomorrow with our very first hashtag Terry Tuesday of the new year. And we will be discussing the scheme, the scam, the artifice that has been created by government and CMS with respect to the fee schedule. So until then, remember, be good to yourself, but more importantly, y'all be good to each other. Take care.